Okay, we're gonna get started. Thanks everyone who's here, and I know some more people will join us as the hour goes on. My name's Shashi Kapadia. I'm an infectious disease physician at Weill Medical College, Cornell University, in New York, and I have the privilege of moderating this session and introducing our speaker. Before I do that, I just wanted to welcome everyone to INHSU Conversations, which is a series that's being hosted by INSHU's early and mid-career researcher special interest group. So I think many of the people who registered for this webinar are familiar in some way with INSHU. And if you're not familiar with the early and mid-career research group, a special interest group, I encourage you guys to check that out. It's a really vibrant international community of folks who are interested in the health of people who use drugs, including hepatitis, other infections, and general well-being. And this is also co-sponsored by the Cherish Center, which is a US-based and a government-funded center, Center for Health Economics of Treatment Interventions for Substance Use Disorder, Hep C, and HIV, that really collects a lot of methodological expertise in the area of health economics. And so as a person who's a member of both entities, I'm really excited that we get to do a joint event together. And um, I want to introduce our speaker, a colleague and friend of mine, Dr. Ali Jalali, who's here in New York. He's an assistant professor of population health sciences at Weill Cornell. He has a PhD in health economics, and then did 2 years of postdoctoral training with us in New York, studying health economics and applied econometrics in the substance use space. And really, his primary area of research pertains to the development and the application of econometric methods for comparative effectiveness and pharmacoeconomic evaluations of healthcare interventions conducted alongside clinical trials. And so he's really developed quite a lot of expertise in this space, and I know that he's passionate about educating others and about these methods and making these methods accessible to a broader research community. So I think this should be a lot of fun. Not much housekeeping, but if you do have questions along the way, feel free to put them in the chat. We are going to kind of save those questions till the end, where we'll do a little Q&A after the end of the presentation. So without any other delay, Ali, go ahead, take it away.
All right, thank you, Dr. Kapadia. I'll share my screen here. Just a minor correction on your introduction. My PhD was in economics and focused on labor, but I've since then been concentrating in health economics. And I don't yet consider myself a complete expert. So consider what I taught, the slides and the topics here discussed that perhaps I may be wrong. I know there's some folks on the registration that are health economists. And so please feel free to ask questions or to provide some criticisms of anything I state in these talks. This will be a broad, as Dr. Kapadia mentioned, some of my research concentration is on sort of econometric methods, but this talk will be more broader since this is oriented for more of an introductory crowd. So with that caveat, I'll go ahead and start. So this is sort of a broad outline of the talk. We're going to sort of discuss the overall purpose and approach to conducting economic evaluations alongside clinical interventions. And we're going to review some of the primary approaches in estimating costs in sort of at a broader level, and discuss some common statistical issues that are encountered specifically around interventions for populations who are either diagnosed with substance use disorders, particularly opioids, or individuals who are use or inject drugs. This talk will be broadly focused on sort of the U.S. perspective, and I know we have a much more global audience today, but this is sort of we have a lot of problems and issues here in the U.S. with our healthcare system, which is not a new fact. And so a lot of us here in the research in the U.S. tend to focus on the U.S. problems. And then at the end, we'll talk a little bit about some challenges that I believe that can be a barrier to the ability for these economic evaluations and pharmacoeconomic studies to contribute to better and informed decision-making in healthcare. So why should we care about sort of economic costs or health economic outcomes associated with medical decisions? Well, I think that probably the best example is what we've experienced in the last few years with the COVID-19 pandemic, that we all are now familiar that the healthcare resources are scarce and limited. And so there are real opportunity costs and trade-offs associated with different policies and medical decision-making. Pharmacoeconomic or economic evaluations can be very helpful to various different stakeholders and clinical decision makers in sort of identifying and determining the best course of action, whether that's a treatment or a prevention policy or strategy in different sort of healthcare contexts and settings. Health economic studies can also draw attention or raise the profile of a clinical or public health problem, sort of broader cost evaluations can really raise the attention for policymakers of a particular problem. And of course, we can, in different methodologies in health economics, sometimes there are these studies around value information, which can provide, can set research priorities and identify potential areas of research that could lead to potential efficiency gains for healthcare systems. At least in the U.S., there's a lot of increasing interest in incorporating and including economic evaluations or pharmacoeconomic studies alongside clinical intervention. This is a work that I published a few years back where we reviewed the not only economic evaluations that were included in NIH-funded clinical trials, but also protocols that had come out. So there's an increasing popularity of these types of studies being attached to or conducted alongside clinical interventions. When we discuss sort of costs, costs are, of course, broken down into both direct and indirect. Direct costs that are usually included in these types of studies are, include all the types of resources that are directly tied to the production or delivery of a healthcare intervention. These can be both medical and non-medical direct costs. Medical, of course, can include healthcare services, diagnostic tests, and other, incorporating also out-of-pocket or other kinds of treatments that patients or participants of the study may consume or utilize. And it includes as well non-medical direct costs associated where individuals have to spend time traveling to and from care, as well as sort of caregiver expenses that are directly tied to consequences of an illness. Indirect costs can vary a lot depending on the disease or illness that you're studying. And these are, of course, resources that are not directly sort of tied to the production or delivery of an intervention, but can include sort of downstream changes. One of the, at least for the area of study that I use in opioid use disorder and behavioral outcomes, that it can impact society, particularly criminal legal system involvement, incarceration. Those types of costs are indirect, but they're very different interventions, whether they're successful in promoting treatment adherence. We often identify sort of important and significant cost offsets down the road. This was based on a sort of a study back in 2020 from my colleague, Dr. Sean Murphy. At least in the U.S. perspective, this is sort of the breakdown of the sort of decomposition of the different cost categories for opioid use disorder in the United States. This would be lifetime associated costs. We can see here sort of premature mortality, those kinds of costs which are associated with it make up sort of the bulk of the cost. But again, sort of criminal legal system costs are non-trivial. They're about 4% in the US. Lost productivity associated with it is around 8%. And sort of the direct sort of healthcare costs associated with opioid use disorder in the US is around 11 to 12%. And so making sure that we account for these decomposition can vary greatly by disease or intervention. But here in the US, I mean, this is how this is broken down. And so it's important to sort of consider all these categories when we're trying to highlight the total cost of an intervention or of illness. Here's kind of an elementary table that sort of outlines taxonomy of different types of pharmacoeconomic or economic valuation studies. The main two that I want to focus on today are these top ones. One is the sort of the budget impact type of analyses, which try to understand, at least from the treatment provider perspective or the agency that's providing care, what are the sort of the real and financial resources that are required to sort of to start up and to sustain an intervention. And the second one is, of course, the broader cost effectiveness analyses, which look at compares outcomes, health related outcomes, as well as the costs of a treatment from different perspectives. I would say that, I think is in prior literature and textbooks, there has been a breakdown between cost effectiveness and cost utility. But more recently, those two have sort of combined into being just generalized as cost effectiveness. You can have both clinical or sort of quality of life based measures to evaluate your health outcome, and they can be considered both cost effectiveness analyses. For those two, so this is, I wanted to kind of break down the real main differences. For the cost effectiveness analysis, the question that you're trying to answer is whether or not this intervention or medication is sort of worth the cost. Are we gaining enough value for the money? And this type of study, we're interested in jointly estimating both the cost outcomes and the effectiveness outcome, whether that is clinical or some kind of broader quality of life measure for each treatment option and intervention, and then compare them together. And the nice thing about these studies is that it provides a comparative analysis of how these different competing interventions can provide value for healthcare decision makers. And it's typically guided by some welfare goals, such as maximizing health benefits or some kind of for population or catchment of interest. The budget impact studies are, the question that they're really answering is the intervention affordable or sustainable for a particular agency or organization that's providing care? In other words, are revenues, at the end of the day, revenues generated going to be greater than or equal to the financial outlays or costs? These types of studies, we're interested in estimating the sort of the real financial resources required to adopt and diffuse a new healthcare intervention within a specific budget or healthcare context, right? Whereas the cost effectiveness analysis, we could be, the context is usually trying to be representative of a more broader generalizable group. And while cost effective analysis is a comparative analysis, these budget impact studies aim to provide sort of real pragmatic information that can be useful for providers to assess whether some new treatment within some limited budget context is sustainable for them. Minimum takeaway I always give in these talks is that, I'm an economist, but I do believe that sort of economic data is necessary, but it's not sufficient for making informed decisions in medical context. What value is it? What's the most optimal decision or treatment policy is really determined by many other non-economic considerations, equity, fairness, and just sort of preferences. We all know there's a lot of, there's a research around how specifically in areas of just to be departing from substance use, but there's a little research that it's really cost saving to adopt for inguinal hernia surgeries to, instead of using commercial mesh, using sterilized other types of mesh products. But you could save a lot of money in those cases, but in sort of high-income countries, these are not being developed, even though it's cost effective. And so there's lots of examples to say that the decision making that are done in policy setting are not necessarily driven by economic information. If something is cost effective, does not mean that it should be adopted. There are other considerations to consider. Another area of research would be sort of rare genetic diseases or treatments like orphan drug medications that most studies have shown to be too high a price for the type of population health improvements, but we still decide to provide those types of medications for individuals. And these are based out of equity or fairness. Well, when we talk about sort of value for money, as I mentioned earlier, how do we assess value? Well, first we have to ask, who are we, value for who? And that depends on the sort of stakeholder that we are interested in doing the analysis for. This could, in the US, much of the health cost effectiveness analyses in the literature sort of focused on healthcare systems and society. And there's an increasing trend to use, having policymakers or some kind of state or federal budgetary stakeholder and looking at their perspective. And depending on what stakeholder you're conducting the study for, that kind of determines what types of healthcare and non-healthcare resources are going to be assessed in the economic evaluation for them. One example could be that policymakers are interested in transfer payments such as unemployment payments that could be incurred due to different treatments. And in a societal perspective, those kinds of transfer payments are often ignored because it's just taking money from one pocket and transferring it to another. It's not necessarily considered a cost. But for a policymaker, a state budget, that is actual sort of a cost item for them. And so that might be something of interest for that group. Now, as mentioned, that cost can be calculated based on a stakeholder perspective. This is sort of a breakdown of the types of cost elements that can be included for these different stakeholder perspectives. Here where, for the healthcare sector, we'll include all sort of direct medical costs incurred on behalf of the participants, which will include sort of inpatient, outpatient, other types of ambulatory care, and it would include also out-of-pocket costs of the individual. And sort of societal costs would be much more broader, which would include things like criminal legal system and labor productivity associated costs. How do we measure value? Of course, there are a set of few different measures that are used in cost effectiveness analyses. The most popular one that's still reported in literature is the incremental cost effectiveness ratio, which is simply just a ratio of the difference in the expected average sort of cost between intervention and control. And since the effectiveness measure is at the denominator, the ICER ultimately can be thought of as telling us that, what is the expected cost for one additional unit of effectiveness, whether that effectiveness is some kind of medical or health outcome, or if it's a broader sort of quality of life-based outcome. Once we have this measure, how do we decide what is valuable? Well, concepts that are used in these types of studies, the first one, the primary one, is willingness to pay, which is really just defined as, what is some maximum price or maximum cost that some healthcare consumers, private or public insurers, or any other stakeholder will pay for one additional unit of this effectiveness measure. There is a sort of a similar concept called willingness to accept, which is sort of the minimum price that one is willing to accept for sort of one negative unit of effectiveness. This is that in cases where you might have a new intervention that might not have as maybe a little bit less effective than a new intervention, but it might be much less costly. And so sometimes we want to, we can identify a efficient, a less superior, but maybe more cost efficient intervention. When cost-effective analyses are usually reported, folks tend to use, there are often multiple interventions or competing interventions that are considered based on compared to your baseline or treatment as usual. And it's been useful to sort of represent those, those treatments within what we call this cost-effectiveness plane, which sort of captures in the x-axis a difference in the incremental effectiveness measure, and on the y-axis a difference in the expected cost. And so usually when we look at these at different quadrants, we find that if intervention compared to a treatment as usual, if it's on the top right corner, we know that this new treatment is more costly, but it also provides more effectiveness. If it's in the bottom right quadrant, which is here highlighted in green, it indicates that the new treatment is less costly and more effective. It's green because that means that this is something we want to adopt. On the top left quadrant, it's red because this means that the treatment is less effective, but also you're paying more for it. And so you're, you don't want to adopt this new intervention. And then you have the bottom left corner, which a treatment is less costly, but also less effective. And so sometimes we might be willing to have less of an outcome if we were able to save enough for that case. Most treatments and new interventions are going to cost more and provide greater effectiveness. So in the top right corner is where we, most studies try to evaluate. And when we think about sort of our willingness to pay, or when we measure sort of the incremental cost effectiveness ratio, we can think of it as a sort of a line that sort of partitions this plane, and whatever slope of that this line is associated with a higher or lower willingness to pay measure. And any sort of, for example, if this line is associated with a $100,000 per additional unit of effectiveness, then any kind of treatment that falls below and to the right of this sort of maximum acceptable willingness to pay line or incremental cost effectiveness ratio line, we can consider that as being providing economic value. If some of the folks here who have seen other papers where they'll use other measures such as net monetary benefit or incremental net monetary benefit, if it's in this region here that's sort of highlighted, then those treatments will have a positive net monetary benefit. Now, of course, in all these studies, we have to incorporate uncertainty around the estimated cost and effectiveness measure of some different treatments compared to a control. And usually in clinical trials, when we do these, we, of course, have some confidence intervals or some measures of variance of both the effectiveness measure and the cost, as well as the joint variance, joint covariance. And so this sort of red line could represents a joint distribution of representing the uncertainty between these measures. And which is nice because when we look at this joint distribution, we see that a portion of it falls to that sort of value area to the bottom right, and a portion of it falls outside of it. And what often we do in these studies is that we look at various levels of willingness to pay parameters that represents the stakeholders' preferences, and we evaluate, what types of, how much percent at different willingness to pay thresholds does the intervention fall under. And so here's an example where this is from a study I conducted a couple of years back on treatment for opioid use disorder, which was a naltrexone treatment, extended release injectable naltrexone. And these dots here represent sort of this uncertainty, this joint distribution of incremental effectiveness and costs. The red dashed line is sort of this primary X and Y axis. And you can use that similar approach, and for different healthcare stakeholder perspectives, we can evaluate in the bottom X line sort of increasing level values of stakeholders' willingness to pay parameter, ranging from 0, in this case, all the way to $100,000 per abstinent year. And at the top and left, we sort of have, which covers, what was the proportion of that distribution kind of falls under that line, and which can be interpreted as sort of the probability that this intervention is acceptable or provides economic value for the stakeholder at different values of this willingness to pay threshold. And we can nicely look at, for example, the 95 percentile range, and find that in this case, we identified that if the stakeholder is willing to pay $49,200 or more per additional effectiveness unit, then we know that at a 95% confidence and 95% level, we can determine that the intervention is probably likely to give economic value for them. In the flip side, in here we have the lower bound where there's 3,150. We can say that if the provider or the stakeholder is not willing to pay any more than that amount, then we can say that there's enough evidence to suggest that this intervention would not be cost effective for this stakeholder. Now, there are sort of 3 common methods or approaches of conducting economic evaluations. We mentioned that a lot of my work is around doing these work alongside clinical trials, but probably one of the most popular approaches is using decision analytic modeling or simulation-based approaches, which are very useful because they provide, they're low cost. You don't have to engage with a clinical team and spend multiple years of conducting a study. So they're much more efficient use of resources, but of course they don't. There are some internal validity issues associated with those. There's increasingly more interest in doing, conducting these cost effectiveness analysis using real world evidence approaches. A lot of that has to do with certain policy changes by agencies in the U.S. and others, where they start to accept evidence for drug safety and other things based on observational data and not exclusively by clinical trials. All different types of approaches. The main aim is to estimate the expected costs and effects and the distribution of these estimates per treatment or strategy arm. Now, for the alongside or trial-based research approaches, it's much more sort of research intensive, and you can break it down into multiple phases. One of the more important phases is that, I've met folks who've interested in including some kind of economic valuation in their trial, but sometimes they wait until much later to engage an economic team. But really, the economic team needs to be engaged with early on at the trial inception. And that's because, we need to be involved in instrument selection. There are instruments that we find very useful that collect really good and valid data on cost and other types of resources that we're interested in. The sample size and power calculations for cost effectiveness studies alongside clinical trials are not necessarily going to be the same as those for the clinical effectiveness measure. Sometimes it can be different. Sometimes the power can be better. We have to, of course, be involved in the implementation phase, because that's where we want to collect information on what are the intervention associated costs and assess sort of economic feasibility and sustainability. We, of course, have to be involved in monitoring the trial, to identify, maybe perhaps, one of the things that occur a lot in the studies that I've been involved in is that we have a lot of high levels of data missingness. And so sort of being available to identify the mechanisms of missingness and addressing sort of those issues are important throughout the trial. And then, of course, at the end, once the trial is finished, that's really where the evaluation phase starts, where we do our statistical analysis. So the economist teams should be involved throughout the whole process of clinical intervention. So it's important to sort of get engaged and conduct collaborative work throughout the whole process. At the trial inception, it's important to sort of include make sure that we collect all the data we want. It's going to be a waste of research resources if at the end we realize we did not have all the data we need. Clinical measures, of course, in my work, we identify through study data, so that be captured itself. When you're including a health-related quality of life type of measure, pre-scored instruments tend to be the ones that are popular and very useful. EQ5D, as well as Promise Proper, are ones that are popularly used in substance use disorder clinical interventions here in the US. When we're conducting intervention cost analyses, these would include, administrative data that's collected. Usually some studies will have an implementation team, but we also want to include, there are structured cost instruments and guides, some that have been developed for drug use treatment, as well as substance use treatments as well. So those are available. For longitudinal healthcare utilization and non-medical costs, there is this instrument called the non-study medical and other services instrument. I will show you a quick picture of those, but that's been very useful. It captures really great and valid information for us. And of course, we collect data on resource use and what kind of healthcare was utilized. But of course, among these studies, one of the things that the economists can do is to try to identify important resource or cost weights to attach to those different healthcare goods or service, a way of evaluating them. These have to be sort of representative of kind of a broader provider or stakeholder perspective. That way, so that it can form multiple groups. But at least in the United States, given the fragmentation of the healthcare system here, this can be quite a bit complicated at times, because the different price and resource weights are important for certain stakeholders and others. Pre-scored instruments, I think most folks are familiar with those. You usually sort of assess individuals around different dimensions of health and quality of life. This one includes, this breaks off, but this is based on a few of these, and usually when individuals report, indicate at what level of functioning they would have on certain these dimensions, and then you have some pre-scored algorithms to then determine a health-related quality of life utility measure. The typical way of estimating these is that we'll collect at different time points of its trial. We'll get a sort of a one-time capture of an individual or group's, the average treatment group's healthcare utility value and for different treatments. And we sort of assess what sort of the area under these curves are and look at the incremental difference to kind of assess the incremental effectiveness on those types of measures. And so all of them typically kind of follow this type of diagrammatic approach. When we estimate sort of intervention or implementation costs, we're really focused on identifying all the real and financial resources that are needed to both start up the intervention. Sometimes the intervention is just the new medication. Sometimes the intervention could be the inclusion of, let's say, a patient health navigator or a team of clinical, maybe addiction specialists to help link individuals to care. And so, there are whenever these interventions are put together, there are some costs that are associated at the beginning of the intervention. And then, of course, there are some costs that are continually required to sustain the intervention or manage the intervention over time, sort of on a day-to-day basis. The main kind of method that's used to conduct this analysis is called microcosting analysis, which is really a fancy way of saying that we conduct sort of these semi-structured interviews with sort of relevant study personnel and staff, and maybe even the implementation team, to sort of assess and question, what kind of resources were needed at different phases of the trial and intervention to both start up and as well as to sustain it. We find that it's been formative to break down these intervention costs into three components. One, of course, will be like the fixed costs that are incurred during the startup phase. This could be sort of, let's say, investments in a refrigerator that keeps the medication at a particular temperature, and these are incurred in the beginning, and certain providers and agencies may need to know what those costs are at first, because even though something could be, the sustaining level of costs over time can be affordable for a certain group, but maybe there's a barrier at the initial phase where there's a lot of fixed investments that are required. Variable costs will be costs that are associated with the total number of each of participants or patients that are served for that treatment. So a provider may have an expectation of how many patients they will see, and so they want to know at what level that they, for their own perspective, what will be those expected costs per patient. Then, of course, we have another category called time-dependent costs, which are useful. These are essentially sort of fixed costs that occur over time, maybe rent costs, maybe an intervention requires, one of the interventions could be that you're innovating around the electronic health records, and so there's more up-to-date info for the provider, and so maybe you might need an IT infrastructure, and that can cost money to maintain, let's say, like a cloud data infrastructure, etc. I'm sure researchers who conduct research with EHR and have to store data somewhere have some monthly fees associated with those can relate. And of course, these detailed information and intervention costs that are collected, can be really useful when and put together into a user-friendly and customizable budget impact tool, where you can go in and the provider or particular stakeholder can kind of adjust their expected number of participants, or they can, if they already have certain resources that was included in the fixed cost analysis, they can ignore those and see what is the additional resources they need and find their own sort of customizable startup costs and continuation costs. For collecting information on longitudinal healthcare utilization and other costs, we find it, at least in the work I do and my colleagues, that we try to combine all those into one instrument and attach it to sort of the clinical intervention team. This NMOS, or non-study medical and other services. Here's an example where it has a number of questions on relevant healthcare resources that are used. For example, question 2 says, have you been admitted into a residential program for detoxification or for other services? How many times and how many stays? And we collect this at different various points. And then at the bottom to the right, you can see there's information that we're trying to collect on, let's say, productivity, schooling, how much time they've traveled to and from medical to receive medical care. Number 10 asks about their occupation and how much time they had worked, so we can address maybe absenteeism or changes in productivity, et cetera. Usually in clinical trials, at least in the US, around opioid use disorder treatment, the study teams will include information, instruments where they'll collect data on criminal legal system outcomes. But if those are not included there, you can always add those in here. And so these ones are sort of flexible and can be customized. And these are available. These types of examples I'm showing are available at the Cherish website, which I'll show at the end. Now, I recently conducted a sort of a systematic review, and we looked at sort of all the different economic valuations for opioid use disorder treatments. I looked at 85 studies, and based on those, covered around 14 national healthcare systems. And there were some general conclusions that we raised, but there's still a lot of questions to be answered. We know, at least from literature, that retention to opioid agonist treatment tends to reduce high-cost healthcare services after treatment initiation. There's sufficient evidence that sort of methadone and buprenorphine maintenance treatment is cost-effective compared to non-pharmacological interventions alone. But all the new formulations of different types of medications, of buprenorphine and others, those, of course, are still new, and so evidence there is still nascent. However, throughout these studies, there's very limited amount of data and information or publications on budget impact. So much of the research has been on these cost-effectiveness studies, but I think these budget impact types of studies are also very informative for those who are involved in actually providing care, but they sort of get a bit of a short shrift in the literature by researchers. This section, I want to talk about some potential barriers that I think that have been limiting the role of economic studies in improving and informing medical care. I'll talk a little bit about some limiting factors in generating evidence based on RCTs for OUD treatment. And then I'll talk about this, one particular issue where, there are some evidence that cost effectiveness analyses and sort of these budget impact studies can sometimes be contradictory, where you'll have a study that says this is cost effective from a social perspective, while the budget impact tool will suggest that actually for those who are providing care they may not find it to be financially sustainable. Now, of course, this is a US perspective. It might be different in other countries, especially those who have some kind of national healthcare scheme or national healthcare provision scheme, and that in those cases, the cost effectiveness and budget data are much more aligned. But in the US, with even our fragmentation, there tends to be some of this occurring where there's a disalignment between the two. Another issue I think what we are very aware of in the US is that randomized controlled trials that are conducted on this substance use disorder population, they tend to be a little different than the actual population that are treated and receive care. They tend to be higher socioeconomically advantaged, be less composed less of minority and marginalized groups. And so one of the sort of the barriers is often that the information and these RCTs and these economic valuations are not necessarily generalizable to the whole population that's suffering from substance use disorders. And so that's important to be mindful and make efforts to make those changes. And this is where perhaps real world evidence types of approaches for doing cost effectiveness analyses can be useful. Some studies that we conduct, this is one of my first cost effectiveness studies in this area, in substance use, can have an issue where when we focus on very vulnerable populations, particularly this study was looking at extended release injectable naltrexone among incarcerated persons before and after release from treatment. One of the main problems with these vulnerable groups are groups that have a hard time accessing care, or maybe there's a stigma associated with them receiving care, is that engagement in the trial and maybe loss, to follow up, or even loss after randomization can be an issue. In this particular study, they were randomized, to about 74 to sort of pre-reentry, pre-release extended release naltrexone compared to post-reentry, and we can see that almost half of the intervention group were lost after randomization. This is a group that were randomized to a particular treatment, but we were lost and were not able to initiate treatment before that. They could have been transferred or mandated to other care. And so, that becomes a big problem, because we have, not only do you have, potential loss after randomization or patient attrition or participant attrition, but you can also have failure to initiate treatment, which can bias results. And when you have comparative studies, between opioid agonists and opioid antagonist studies, this becomes an issue as well. And there's been other studies where we see this sort of differential treatment initiation failure between those, which needs, where statistical methods need to be considered to adjust those. And this one, of course, when we find, at least for this study, where we had really, really high proportion of attrition over time. And so some of these studies, when we focus on very vulnerable or groups that are in most need of care, it's often difficult to get really nice, robust, complete data on the group. Also, enrollment can be very challenging. This is based on a study where we looked at sort of expected mothers with opioid use disorder. And so the blue line, it was, the black line at the top is a proposed enrollment. The blue line was the expected enrollment. And we can see that there was really a lot of struggle to try to keep up with that enrollment figure. And so not only will you have, some failure to initiate treatment, loss after randomization, but sometimes the enrollment, expected enrollment could be much lower. And so this really impacts sort of the statistical robustness of results. Another kind of issue could be that, when we do cost effectiveness analyses, the correlation between cost and effect outcomes can really dramatically impact your statistical inference or measures of whether something is cost effective at a given level of willingness to pay parameter. So it's important in a statistical analysis to, fully capture the real observed correlation structure, because if there is really high positive correlation, which is in case one, then you can you tend to have a much more your greater power in determining the joint difference in effectiveness in the cost effectiveness, and you have the opposite for the case of negatively correlated. So one of the advantages of doing clinical, collecting participant level cost and effect data directly in a clinical intervention, as opposed to sort of a simulation-based model, is that you get to actually observe this correlation structure and then can try to maintain that in your statistical inference, where in sort of these broader studies, we don't necessarily get a good sort of valid information on that correlation structure. And that correlation structure can be an artifact of a simulation model's sort of structure or parameters, which is something we'd be interested in. Now, this, as I mentioned earlier, about the potential discrepancy or contradictory nature between cost effectiveness studies compared to sort of budget impact studies, which are really trying to, one can be very informative for those providing the care, and the other can be more informative for society in general. And I know this is, of course, a bigger issue in the US, and other systems may not be as much of a problem. I think I once gave a talk at a university in Göteborg, Sweden, and I was talking about sort of missing data and loss, and they didn't seem to have that much of a problem because they have a national registry, and so they tend to have great high level of continuity of data and information for their studies. So this picture here, I kind of have an economist on the left. This is big generated on ChatGPT. The economist is here saying that money is value, but the sort of the provider on the right is saying, but value is not necessarily sort of money. And what I mean by that is that, there's this difference between sort of financial and sort of economic costs. Financial or accounting costs of a treatment is, of course, going to be equal to sort of the expenditures or outlays that are paid for a good or service. Economic, or sort of these opportunity costs of treatment, which is what the economists say, money is value. This is what we mean by value, is a sort of the expected value of the next best use of the resource that's employed in providing the treatment. You can think about it as a sort of what is the value of a emergency department visit, right? If a person with an opioid use disorder, maybe someone has an overdose, is admitted to an emergency room, they may consume a whole different set of, care and medications, and different providers show up. But so that could be the financial actual cost, would be sort of like, what are those financial outlays? But to us, I mean, that when you have a treatment that reduces one additional, emergency room visit, for us, the value that's saved is not necessarily the money that was not spent or incurred by the payer, but actually, what could be that emergency room bed used for next? It could be someone who has had some other injury or some other kind of condition. And so we kind of think about sort of averaging like what the use would be for that emergency room. And so we think of the cost as being sort of that next best or use of that resource, instead of the actual direct financial accounting costs associated with that resource. This is, of course, a general cost concept, but it's often proxied by average or marginal costs. or sometimes maybe it'll be a unit price, and I'll talk a little bit about that here. It's a lot more difficult to get this sort of economic value cost in the US and other folks when you have a system where, for example, in the UK, where you kind of have a global payer, you have sort of one price that's on the treatment across everywhere. And so that was that could be used as your resource weight, but in the US, it's a bit more difficult. Now, economic costs, of course, from an economic perspective, we prefer economic costs over the financial costs, because at the end, we're trying to inform decisions regarding competing claims of different healthcare resources. And so we want to make sure that for optimal resource allocation, that you look for, what's that next best use, right? It's not necessarily how much financial money was saved. That doesn't tell us about sort of real resource allocation. This also is important because it can account for resource use that incurs zero financial costs. Some caregiver expenses, for example, are a burden on society. But if you're just interested in what financial outlays are paid or given for a particular good or service, that will not be captured there. But that's an important feature that we need to get. And so this is sort of this difference. But of course, this difference becomes conflict, leads to some conflict between when you're looking to do cost effectiveness analysis to inform decisions at a broader social level versus a budget impact analysis where you're trying to assess whether some intervention can be affordable for a certain setting. For example, here at providing medication for opioid use disorder in jails and prison facilities, which was found that it'd be sustainable. But on the left, we did not have enough evidence, given sort of all the missingness that we incurred, to say that whether something is cost effective from society in general. Now, of course, when we think about financial sustainability, really the interest is on assessing sort of the net revenue changes of providing treatment and sort of the operating expenses. These can be very highly variable across groups. And so sometimes even when you're conducting these budget impact studies, this is why it's important to make sure that those budget impact can be customizable and could be, while you're trying to represent a general group or a general setting, you want folks who are particularly want to make that decision to adopt to be able to assess their own sort of financial risk and exposure. Sometimes a lot of folks, do subsidize, at least in the US, different treatments by cross subsidization. And of course, reimbursement policies can vary by different states in the US, which means that that's an important case to change those resource weights. I know we're kind of running out of a little bit of time. I want to make sure there's enough time for questions, so I'll maybe go a little bit quicker here. But at least in the US case, one of the problems is that we know from like basic economic theory that in competitive markets, sort of marginal incremental costs are going to be approximately equal to like the market price, so what the price we actually pay. And so we know that if a provider is operating at full capacity and efficiently using their resources, then sort of their short run average costs are going to be equal to their marginal costs. And so, we in the US studies can sort of approximate sort of opportunity cost or value by just looking at the average cost of a service. So the average costs that, let's say, Medicare or insurers will pay for one emergency room department can be used as a value for that case. What does this mean, at least for the US context? That means that, well, if we have a less efficient healthcare system and a less competitive healthcare system, that means that the costs and prices that we observe may not approximate economic value as good as other cases. This is, of course, will be an issue for us in the US and other systems where you have a global price. That may not be much of a concern, but if you're conducting a study in a healthcare system that's fragmented, is less efficient, we would want to make sure you conduct some sensitivity analysis around those price figures. What is to be done, at least in the US, I think what needs to be done is that we have to make sure that we conduct both these cost effectiveness and budget impact studies together for the interventions, and try to use that data to sort of inform payment models and reimbursement policies to make sure that when we have something that's cost effective for society, that it's affordable for the provider and not vice versa. And of course, at least in the US, there's a lot of initiatives to do this. This is the Health Economic and Justice Community Opioid Innovation Network, which is sort of a research hub of 11 different clinical intervention studies and centers, which a lot of them have included economic evaluations, and a lot of them have both a cost effectiveness analysis and a budget impact study combined together. And so these can be very useful in doing those together. So my recommendation is to have both those kinds of analyses together in one study, and to have both of those studies being conducted alongside the clinical team along at the trial inception, so that we get really good, valid information across those with that team. So final slide, some of those resources and instruments we were talking about are available at cherishresearch.org. So here's a little clip of our of Cherish. We provide sort of consultation service. There are pilot grants available for new researchers, and we have different sort of slides and other resources on methods and population modeling. So please check that out. And with that, I will maybe hand it back to Dr. Kapadia to lead some of the questions.
All right, great. Thank you. Thanks, Dr. Jalali, for a really interesting talk and great overview. I see there's one question in the chat from earlier from Dr. Brothers, and I'll just take the prerogative, I guess, of reading it a bit. But so in clinical and epidemiological research, there's been strong movements to involve people with lived experience, community groups, drug users, unions, et cetera, as research partners to make research more rigorous, relevant, impactful, even though this challenges some traditional positivist epistemology about objectivity. Is that happening in health economics studies as well? It seems like there are a lot of assumptions baked into each step, and I wonder if involving people with skin in the game in something like cost effectiveness analysis may improve the work or create tensions related to equity and fairness. Is that something you guys have engaged with?
So I know that some more recent, grants and research project what I've sort of submitted with collaborators, we have sort of tried to incorporate, and some have directly sort of folks with lived experience. I think this is a general kind of movement. I think it's important, at least, for example, when we want to capture important resources that are sort of non-healthcare related, that might be important. One of the researches I've sort of been interested in conducting is to focus more on sort of employment outcomes and sort of the socioeconomic needs and not just the healthcare needs of groups. I don't have much expertise to talk about the impact on scientific objectivity of that impact. I think at the end of the day, we want to make sure that these types of studies are informing decision makers. And the decision makers are supposed to make decisions on behalf of those who are impacted. And so it's important that their preferences and their the folks with skin in the game that are baked in or sort of at least informs these studies quite well. I'm not so sure how to address the scientific objectivity, though, at this point. I don't know how it would sort of bias, because we will include these instruments that have been validated to collect and those types of, perhaps it would, in the ultimate conclusion of saying whether something could be cost effective, that could have an impact by the incorporation of folks with lived experience, and perhaps how do we value sort of non-healthcare outcomes for these groups. So there may be, in terms of the narrative of policymaking, but that's general in all types of policymaking anyway. So I don't think it may not affect the scientific objectivity of actual the estimates of costs and effects per se. But in terms of how it can inform policy and lead to change and adoption of new care, I think that's important to involve folks with lived experience anyway, and as a way of decision making. I'm not sure if I answered that question well, but that's sort of what I've been thinking about lately with regard to this topic.
Great, thanks. And I just want to acknowledge Bothwell Pindewe, who chimed in with the fact that this is a consideration in some countries with established HTAs like the United Kingdom, which is great. A question also from Adelina in the chat. Do you usually include the cost of premature mortality? I believe you alluded to that in the slide. So, for example, overdose mortality in your analysis, and if so, how do you do that? Is it the lost productivity, the cost of life lost? And to quote the question, it seems like there are different approaches and some are debatable.
Yeah, so in when we do the cost effect analysis, we don't include that. That graph that was earlier, that was sort of the costs, sort of the societal costs of opioid use disorder in general. I think for, when those kinds of studies, you're trying to raise a profile, raise attention, and sort of bring attention to an issue. And for policymakers, sort of the incorporating sort of premature mortality as a cause is important because it can tell you what the overall burden of a disease or illness is. In a cost effectiveness analysis, we don't incorporate that, at least in our studies, we don't include it. It could, because one, it's a large debate, at least there's a large debate in the value statistical life of what that measure would be. It also, it comes in the area where one would have to directly value, what is the, cost of a addition excess mortality here. So we don't include it there. We're kind of explicit. I don't recall what the guidelines were for it in cost effective analyses at the moment, but when we do these overall cost of illness or burden studies, they are included there because ultimately those studies are supposed to inform what illness or condition is a major problem right now for a given healthcare system or economy. And so premature mortality is an important feature of that, to at least raise a profile. We could see it could be very great. So if we exclude it, you might not think that the opioid epidemic is as costly to society as it is. Regarding productivity, we do incorporate those short-term changes. In the cancer literature, for example, absenteeism due to different chemotherapy treatment regimens can lead to different symptoms. And one of the important values that we want to incorporate is if there some have less symptoms and folks can maintain their social and economic life and have less disruptions, that's an important thing to consider. And we consider as well here, because one of the components of recovery, at least in the US, is considered is to be able to have a normalized, for at least for substance use disorders, especially opioids, being able to have a normal engagement with the economy and get back on your feet and sort of work. These are important values for individuals who are undergoing treatment. And if you look at qualitative studies, I've seen it, for example, those who are involved with the criminal legal system, a lot of them, from the patient's perspective, they report that wanting to find a stable employment, finding a job is important for them. And so we want to find those interventions that are going to be valuable, not just for the payer, but also for those who are receiving the care. And so productivity levels, whether they're able to go back to school, as a slide with the NMOS showed, or being able to engage with find some employment and work a few more hours a week, that's an important part of self-esteem, at least for these groups. And so we do include productivity changes. We don't include at least for these cost effectiveness alongside clinical interventions, the premature mortality costs there, because it could also, since they're so large, it could mask some of the smaller short-term cost and resource changes across different interventions. And plus, they're included anyway as part of the when we include quality of life, or so it really shows up in the effectiveness measure instead of the cost. So we don't want to double count it on both cost and the effectiveness. So it's already accounted for in the health outcome. But when you're doing the overall burden, since you're only looking at cost, we don't incorporate a health outcome in there. You want to include those morbidity associated costs or the premature mortality. Yeah.
All right, well, we're just at the hour, so thanks everyone for attending. Thank you, Dr. Jalali, for a great talk, and we can close out.
All right, thanks, Shashi. See you, folks.